Good morning, everyone. I'm Dr. Deeksha. My topic of discussion is clinical outcomes of retropupillary iris claw IOL fixation in pediatric age group. All the authors have no financial interest. So the options for surgical correction of aphakia in absence of sufficient capsular support include anterior chamber IOL, scleral fixated IOLs, and iris claw IOLs. And there is no consensus in the literature on the best of these. All have their own set of complications. So we discussed the iris claw IOLs. This was first introduced by Jan Wurst in 1978. It is around 8.5 mm long with a central 5 mm optic, and it has notch on both the haptics to grasp the loose iris tissue. The lens has an interior vault of around 10 degrees at its apex, and we conducted an ambispective study. It was an ambispective cohort study. We had planned a prospective study, but because of COVID, we had to convert it to the ambispective one. We had a retrospective arm, which included patients who were operated between Jan 2019 to August 2020. Ethical clearance was obtained in August 2020, and patients who were operated after that constituted the prospective arm. So the patients were 5 to 15 years of age who met the eligibility criteria and were willing to participate and follow up. Preoperative workup and surgery was done, and follow-up was recorded at 1 month, 3 months, and 6 months. Patients with anterior segment dysgenesis, uncontrolled glaucoma, irregular pupil, retinal or optic nerve disorders which could affect the visual outcomes were excluded. So there were 50 eyes of 28 patients. The mean age was 8.32 plus minus 1.5 years, and 21.4% were females. The most common diagnosis was ectopia lentis with no systemic association. This was followed by ectopia lentis with Marfanoid habitus but not established Marfan syndrome. Next was microspherophakia and ectopia lentis with diagnosed Marfan syndrome. The best corrected logMAR visual acuity improved from 0.86 to 0.9 at 6 months follow-up. The axial length, keratometry, and white-to-white values were again in the normal range. Another important feature that we noticed was pupil ovalization, which was noted at day 1 post-op. However, at 6 months, the pupil became circular, and there was no difference in maximum pupillary dilation. The maximum mean pre-op pupil diameter was 6.2 millimeters, and post-op also the pupil dilation varied from 5 to 7.5 millimeters. And hence, we can say that these IOLs do not interfere with functioning of dilator pupillae and fundus evaluation. Next thing is endothelial count. The mean pre-op specular count measured on IDEX specular microscope was 3239 cells per millimeter square, which dropped to around 3150 cells per millimeter square at 6 months post-op, and a 2.8% endothelial cell loss was noted at the end of 6 months. The effective lens position of the IOL was measured on UBM at follow-up of 6 months to assess centration and inclination, and the value of effective lens position varied from 2.23 to 5.2 millimeters. Again, this can vary with the axial length measurements. All the patients, there was no increase in central macular thickness. None of the patients developed macular edema over the 6 months follow-up. The complications that we found were disinclination, which was seen in 4 eyes. 2 of them were post-traumatic and 2 were spontaneous, where the history of trauma could not be elicited. 2 patients developed hyphema on post-op day 1, and on inquiring, we found that the child was very naggy and he had rubbed his eyes on the post-op. In 7 patients, there were corneal edema on day 1 post-op, which subsequently resolved in around 1 week. And 3 patients had hypotony, which needed wound resuturing. So I would like to discuss about disinclination. On 4 out of 50 eyes, there was disinclination. 2 of them were spontaneous. 1 patient had a temporal disinclination and other had nasal and anterior. And this was seen at around 20 months after surgery. Though we had a follow-up of 6 months, but these were the ones which came to us later, and hence we included them in the presentation. And other 2 were post-traumatic. So these are the clinical pictures where we can see the inferior disinclination, and here the nasal haptic has been disinclaved. All the IOLs could be easily re-enclaved, and the best corrected visual acuity obtained was 612 or better. So to conclude, retropupillary iris claw IOLs are safe to use in children with subluxated lenses. No corneal decompensation or pigment dispersion was noted, and there was no significant drop in endothelial cell count, and there was no case of inflammation or CME. However, longer follow-ups are needed to ascertain the safety of these lenses, as iris atrophy and pigment dispersion was not that apparent at 6 months follow-up. Thank you.
So in the clinical photographs I saw, I could not find a peripheral iridectomy. So
No, sir. For retropupillary iris loss, these lenses have a posterior vault.
okay.
We insert the lenses. These lenses, ma'am, few of them were artisan lenses and rest were Lensai optic. Lensai, Lensai. It's an Indian company. The cost of lenses is around 1,500.
Did you do? Yeah.
Yes. So
Okay,
this
okay, okay,
vault
okay.
goes posteriorly. We do not need a
Okay,
PI
okay,
for retrofixator.
So did you look at what the genetic analysis of the patient was before choosing a posterior iris claw lens? Was there any indication? I know you said
No. All cases of subluxated lenses, we
because there is a subcategory of subluxated lenses which might not have a systemic involvement, but they have pupillary involvement, and their disinclination rate might be higher. For example, in ADMS mutation. So did you look at the genetic profile or
no,
just
ma'am,
the
genetic
system?
profile was
You look
not.
for systemic associations
Only
and
systemic
then
associations based on clinical features. Genetic evaluation was not done.
About the endothelial count also, it's a very short this thing. You have been doing for a longer time because
Yes, we have been doing for a longer
so
time.
do you
but
have any I mean not related to this presentation, but do you have any data on
no
that?
significant, like the endothelial count has never dropped that low to cause any corneal decompensation, and even other studies have reported around 2 to 8% of endothelial loss, and we also got around 2.8% at the end of 6 months.
And about the hypotonia, I wanted to ask you whether because when we do initially, can we do a secondary iris claw and because we do
Yes,
a vitrectomy and everything?
can also be done.
Have you done any comparison? Because
No,
I'm
all
just
the
asking.
children underwent
Primary.
Yes, primary.
AC maintainer. Did you use?
No, we under OVD, the cohesive OVD.
all surgeries were done by the
Same surgeon.
Dr. Coker did.
Yeah.
Okay.